Welcome, everyone. Hope everyone is off to a great start to their day, or has had a good first half of their day, depending on where you are in the country. Folks are still kind of popping in from the waiting room, so we'll give folks a second here and go ahead and get started. Welcome to AIDPH's 2025 Rural Oral Health Seminar Series. This is the first seminar of our year here today. We're so excited. We are talking about Beyond Service, addressing oral health barriers for rural veterans today. We are thrilled to have Bobby Jo Steele with us here today, presenting from Marshall University. It is our honor to be able to hand this over to her in just a second here after we go over our housekeeping. And thank you everyone for being here today. We can go ahead and go to the next slide. Okay, so looking at our agenda today, I'm just going to give us some quick welcome and housekeeping pieces. And like I said, hand it over to Bobby to talk about our didactic presentation looking at oral health barriers for rural veterans. We will, of course, have participant Q&A and community discussion. I know Bobby will say this when she starts her presentation, but our aim is always for these sessions to be as interactive as possible. So please post your questions in the chat, participate in the conversations that when we have those throughout, and we will make sure that we have a robust community discussion. So we can go ahead and go to the next slide. We want to say thank you to our partners on this session. And go to the next slide. So our housekeeping here, this session is being recorded. I know a lot of folks here are joining us live. We're in our live session. We will also be posting this asynchronously. So as you're watching this, you may be watching this asynchronously on our Academy. If you have colleagues that you want to share this, we will share the recording out afterwards. And you can also go back for reference as well. Along with the recording, we will have all session materials, including the slide deck, and any resources that we share will be available on the Academy. We ask that you avoid sharing any PHI or PII in this session. Again, this is meant to be interactive, so please type your name and email and organization, introduce yourself in the chat. We also encourage you, if you are able, to come on camera, so again, we can be here in community and discussion. If you have any questions specific about Zoom, you can message our staff. We have Shayla Stewart on the call, Samantha Lassett, and Christine Coffey are all AIDPH staff members. They can say hello in the chat and let you know that you can give them a DM if you're having any technical issues. You can head to the next slide. So just a quick overview about AIDPH. Our mission is to empower our community to advance oral health through science, education, and advocacy. Our community is the dental public health workforce, and that is you. So thank you for being here today and taking time out of your day to get activated on this topic and understand how you can make change in your community. We're thrilled to have you all. We do this work because we have a vision of a justice-oriented oral health system. You can head to the next slide. With this work, we have 4 communities of focus. That includes LGBTQIA+ people, veterans, people with disabilities, and people in rural communities. This seminar series focuses on rural communities, but of course, if we go to the next slide, we understand that there's a great amount of intersectionality amongst those communities. For example, we're talking about rural veterans here today. We know that veterans disproportionately live in rural communities. And when that's the case, we see those disparities and those barriers to care kind of multiply and make access even harder. So really great to kind of dive into that intersectionality today. You can head on to the next slide. This is our AIDPH Academy. I referenced that a little bit ago. So again, we're in a live session here today. These seminars will also be available asynchronously on the Academy, which is the umbrella and the digital space where we house all of our educational and leadership programming at AIDPH. We have everything all the way from one-off webinars to a series like this, certificate programs, fellowships, and our annual colloquium, which I think some of you were just with us a few weeks ago at our 2025 colloquium. Can head to the next slide. Okay, these are our session norms. We want to make sure that you understand that this is an all teach, all learn opportunity. We use first names to facilitate equality in the discussion. We want to hear from everyone. Everyone's voice is equal. We invite you to add your pronouns to your Zoom name. And again, I see it rolling in with the chat with folks introducing themselves. I see that everyone's getting ready to engage. Again, please keep your video on, but yourself on mute until we're engaging in discussion. Limit distractions so you can be with us fully here today, and be respectful. It's okay to disagree, but do so respectfully, not disrespectfully. And again, respect patient health information. You can head to the next slide. So again, this is our first Rural Oral Health Seminar of the full series in 2025. This is our 4th year doing this series. So I referenced the Academy before. If you were interested in previous years' programming, we have all of those sessions available asynchronously. You can go back and earn those certificates and those CEUs and reference those seminars as well. This year, we are carrying the theme from our annual colloquium, Dental Care is a Human Right, over into this seminar series as we're celebrating our 10th anniversary as an organization and really honing in on this theme. So we'll be exploring how recognizing dental care as a human right can drive policy advocacy and innovation in rural communities to advance oral health access. Again, building off of that conversation that we started as a dental public health community during our colloquium. CEUs are available for each session that we have in this series. We will post the link in the chat at the end of this session that you can go to the Academy and fill out the CEU request and evaluation form to get that. It will be tracked for you in the Academy. And if you are watching this asynchronously, that evaluation and request form will pop up for you at the end. Additionally, this is one in a series. So if you participate in all of these, either live or asynchronously, and complete the competency quiz at the end of each one, you will be able to earn a certificate in advancing oral health justice in rural communities. You can head to the next slide. This is just showing our dates. We host these every other month, so be on the lookout for registration sessions, forms for upcoming sessions. Mark your calendars. We're excited to have you join us throughout the year. You can head to the next slide. These are our learning objectives, and I know Bobby's going to go over these more, so we can go to the next slide. Also sharing that she doesn't have any disclosure. So as I said, I'm really excited to introduce Bobby. To get us started, Sam is going to launch a poll for us, and we want to hear from you about which of the following do you believe is the most significant barrier to oral health care for rural veterans. So Sam's going to pop that up, and we will give folks a minute to answer this poll. This will give us a great start to kind of understanding where we are as a group, kind of what we're looking at as we go into this. And as folks take an answer in that, I'm just going to give you a little bit of a background on Bobby Joe. She's an MPH and RDH CTTS. She joined Marshall University Joan C. Edwards School of Medicine 15 years ago. She manages the school's community oral health projects and programs and dental grants. And during her time at Marshall, she has pursued her passion for helping improve the overall health of fellow West Virginians and all of Appalachia. And I just want to say that I have had the privilege of working with Bobby on several different projects and several different advocacy pieces, particularly around veteran oral health. And she is just an amazing person and a wonderful champion and advocate. So when I say it is my honor that we have her here today, that is true and heartfelt. So we'll take a quick look at these poll results. I'm seeing that, some folks are still chiming in here. We have about 83% of participants. 46% of people are saying the lack of dental insurance they see as the most significant barrier to oral health care for rural veterans. But we have 20%, 15%, and 20% respectively for shortage of providers, transportation and geographic isolation, and limited awareness of available resources. And for those watching asynchronously, while you're not able to participate in this poll live, we suggest that you take a minute and think through what your answer would be on that. Okay, I'm going to share out these results, and Bobby, I will pass it over to you to get us started. Thanks so much.
Thank you, Liz, for that warm introduction. And likewise, I am honored to work with you and your organization fighting the good fight out there. So if you want to go ahead and go to my first slide, or are you going to share the poll results first, or we'll go? Okay, we'll go ahead and get started. And happy, I think it's someone told me it was World Oral Health Day. So happy World Oral Health Day to everyone. I didn't know that was a thing. But with that being said, I am Bobby Steele from the Marshall University School of Medicine, and we are located in Huntington, West Virginia. And for those of you that are big football fans, you've probably seen the movie We Are Marshall. So if you watch that movie, you'll know a little bit about our small community and our university. So you can go ahead and go to the next slide. And as Liz said, I do not have any relationships to disclose or any financial things to reveal. But if somebody would like to pay me to do this, by all means, put it in the chat, and I will be glad to take some money. But as Liz posted the objectives, I'm not going to read those to you. I think everyone's capable of doing that. But basically, by the time that we end our time together, you guys are going to know a little bit more about what the veteran population in general faces, particularly in West Virginia, and what we are doing here at Marshall to eliminate some of those barriers. And we're going to share with you some of the things that we're doing that we have found useful and helpful in breaking down some of those barriers and helping increase our veterans' access to oral health care. Next slide. And you already got to know a little bit about me. And I am the division director at the School of Medicine for the Community Oral Health Division. And I'm a part of a dynamic group of public health hygienists, and that's our picture there. And veteran oral health is really something that is very near and dear to our hearts. Two of our team members are veterans themselves, and every one of our team members either has an immediate family member who has served, is serving. And so for us, this is really an important topic. And for me, it's extremely personal. My husband retired from the Marine Corps. That's our picture over there. After 22 years, he was part of the Special Operations Command. He did numerous combat tours. He even has a few countries he's not allowed to go into because he would be a threat for information. And was awarded a Bronze Star for Valor. He has a Purple Heart. And yet he has to drive over an hour past 13 dental offices to get free care with our veteran at our veteran hospital, our closest one. And if he chose to do the community and care, there's a whole bunch of paperwork, and then then there's a big wait list. So for me, it's really personal, and that's my why. And I think Liz mentioned this and what their mission is, and that's really what matters to all of us, is our why we're here. And when we share our why, that makes people perk up and listen. The data is nice. Those success stories are great, but the why is really important. So as I go through this, think about your why. There's a reason you're here. Maybe it's just to get the free CE credit. I don't know. But there's a reason that you decided to join us today. So think about that. And as we go through the day, if you guys have any sort of things you want to share or input that you want to add, if there's something that I talk about and you're like, oh, we're doing that, but we're doing it better, or we're doing a different approach, by all means, put that in the chat. Liz and Sam, I think, are going to be monitoring that, and we'll throw that. Yep, I got the thumbs up. So by all means, please do that, because that's what we want this session to be. So next slide will tell you a little bit about what our team does here. This lay the foundation. Veterans is just a small portion of our work, but we do direct services at free and charitable clinics. I see patients at the homeless shelter. We do all kinds of special events. We manage all of the community outreach with our general practice residents. We conduct our research. We do community baby oral health showers. I mean, you just never know where we're going to pop up. But that's one of the reasons I love my job too, is no day is exactly the same. And that goes for our entire team. So this gives you a little bit about what we do. So now I'm going to tell you about where we do it at, and you can go to the next slide. For those of you that aren't familiar with West Virginia, we are our own state, contrary to what ESPN reporters sometimes say, it's Western Virginia, and they don't realize that we are not, Roanoke is not a city in our state. The little thing happened called the Civil War when we became our own state. Our population is only 1.7 million. So there are a lot of cities that have a bigger population than our entire state. We're the only state that's entirely in the Appalachian region, which is one of those claims to fame. And anybody that knows anything about the Appalachian region knows that the people here are very unique and caring. And that's something we take great pride in. Some of the things we are not so proudful of is we have one of the highest poverty rates in the United States and the lowest per capita incomes. We're 48th in education and 47th in economic well-being. And that's a little disappointing, but also adds some additional barriers when you look at veterans care and really oral health access overall. We have one dental school, and it is at WVU, West Virginia University in Morgantown, West Virginia. And we have 3 medical schools. We have 4 veteran hospital centers, and we have several counties that don't have any dentists at all. And we have 55 counties. So if that gives you an idea of what some of the barriers we face ourselves, and there's probably some states that are very similar to that. I know there are some frontier states that you might be a lot bigger in size, but your population and your economic factors are very similar to us. All right, so the next slide. And I always share this anytime I present at a national conference or to talk about our access. When you look at West Virginia, it looks like from Marshall University to one of our school-based health centers that's located in Westside, Wyoming County, as the crow flies, that's 60 miles. So that should be, maybe an hour, a little bit. And it looks like everything within West Virginia should be reasonably close. But the reality of that is on the next slide, you will see that it's going to take you over 2.5 hours to get from West Side to Marshall. If you are there and need an oral surgeon, it's going to take, there's, I think, maybe 3 in the state that are taking Medicaid at the present time, WVU, Marshall, and one of the private practice folks. So if you're going to have to go see an oral surgeon and you live in one of these rural areas, not only that's an actual picture of the road that you're going to have to take. So I love showing that. You get car sick, you definitely want to take your Dramamine if you're coming to visit us. But when you think about even something like an oral surgery visit, you usually have to have a consult. And depending on whether you have access to Wi-Fi and what kind of technology that your referring dentist may have, you may have to make a trip. And that's, that 2.5 hours is if, 1, you don't get behind a coal truck, and 2, if the weather is very cooperative. And very few times does that happen here in our state. And if you're going to have an oral surgery visit, when you day of your procedure, you're probably going to have a driver too. So those are some of the barriers that we face when you think about access to care. And that's just one example. And the next slide will show you what our veteran accessibility is. Those are the stars are our 4 VA hospitals and where they're located. And when you look at where our major highway systems are, they're really not close to a lot of our population. The Martinsburg area, I love that part of our state, but it is truly a bedroom community of Washington, D.C. And it's really not representative of the rest of our state. So when we look at veterans, they really face a lot of transportation and geographic barriers. All right, so the next slide, I'm going to tell you a little bit about how we got involved in looking at veterans. It's been several years ago when some things changed and the VA went to covering only those that had 100% disabled that they would see. And we were seeing this influx of veterans with care that just was crazy. And we're located in a city with one of those local VA hospitals. And so they didn't have coverage. They didn't really know what to do. The VA was referring all these patients to us. And one of our local funders was at a meeting and this got brought up. So they came to us and said, why don't we do a RAM project or a Mission of Mercy just for veterans? So we brought a group together, and when we sat down and we're talking with that funder, folks at the VA, those within our department, we determined that really wasn't, and I was pretty vocal and kind of got in trouble after the meeting, but I said, that's not acceptable. And having my husband, like I said, having that background, I was like, we can't we can't just do a one and done. Our veterans shouldn't have to decide what service they want and then have to go another year. Like, we need to provide truly comprehensive oral health services, and they deserve that. So the funder at that time was like, you know what? I think you're right. We don't need to just do a Mission of Mercy or a RAM project where it's one day and we're done. So we did some planning, and we did our first pilot. And Highmark Blue Cross Blue Shield was one of the funders, and you can see us there the day that we did that. And we saw 24 veterans that day. We had pre-screened them all, members of our public health team, because that's one of the things we're allowed to do with our scope of practice. So they went and we screened all of these veterans and kind of got an idea of what we did, the x-rays. And then we worked with our providers to kind of do a rough treatment plan, because we're still not allowed to diagnose as dental hygienists, but we were able to work with them and get an idea of what they were going to be needing. And we got them on the schedule the first day with either one of our attendings or one of our residents or one of our hygienists, and started that treatment and did a comprehensive full treatment plan. And over the next 9 months, we were able to complete all of those treatment plans. And with the support of the Highmark Foundation, we didn't run out of money, which was great. We were very close because some of those treatment plans got to be very extensive. And I always share this story about one of our veteran patients who has just become I mean, he's part of our team at this point in time. He has all of our cell phone numbers. He texts us good morning. He brings us things when he comes to the office. But he was one of those that had assumed that he had full coverage at the VA. He had, for those of you that are dental providers know what tori are, they had removed his tori so that he could have some partials. And then he was stuck because he couldn't get the partials because they weren't covered. So he was really caught in between, you know, the care that was covered from the medical side versus the dental side. And he said he always, you know, he'll give a testimony and tell you like how valuable that was, that we were able to follow that care and give him back his smile. And we really, really have found this really impactful. Well, because of all that success and the, you know, some of the publicity we got from that and the sharing from our funder, we were able to expand that into an every year event. And we also have gotten involved with expanding some of those focuses and looking at, you know, access to care issues. We have a grant from the CareQuest Institute where we're looking to increase access to oral health services across West Virginia for all those veterans. And that includes listening and learning sessions with our providers. We're doing oral health surveillance on seniors, which is kind of exciting, or seniors, good grief, sorry, veterans, switching gears with our veterans, which is exciting because, as to our knowledge, I don't think that's ever been done, where we're actually looking at their mouths, asking them directly, what are your barriers, looking at what their needs are. And we're hoping to have some exciting things to report from that. So with that being said, I'm going to jump in, and I know that Liz covered some of this initially about the, you can go to the next slide, of what our veterans face. But in West Virginia, I'm just going to share this real quick. You know, we have one of the highest percents of veterans. You can kind of look at the statistics there. We have a high unemployment rate. 8.7 of our veterans live in poverty, and the median household income is really low in comparison. And then we have almost 27% that have a service-connected disability rating. But with that being said, I'm not going to spend too much time on West Virginia. So you can go ahead and go to the next slide. And when you look, and this, for those that are healthcare providers, this isn't going to surprise you. And this isn't just for West Virginia veterans, this is for all veterans. But those who have served are more likely to have experienced physical health challenges and include higher rates of chronic disease and chronic pain. And I mean, they have lower rates of being able-bodied. But when you think of the stuff that our veterans have gone through and done, this isn't surprising at all. And these comorbidities, this is just a few of those ones that I, you know, chose to list, because these are things that have a direct impact on their oral health and the oral cavity as well. When you think about diabetes, cancer, you know, chronic pain, arthritis, even holding a toothbrush, hearing impairments, all of those things directly have an impact on the oral cavity. So that's why I went ahead and included these. And like I said, we could spend a whole day on those comorbidities and how they impact those that we serve. But I'm just going to touch on that just a little bit. And if anybody has anything else to add, by all means, please do so. And Liz, I assume you'll stop me if anybody puts anything in the chat. And okay, wonderful. All right.
I'm just double tapping on folks. Don't be shy about posting it in there.
Yes, by all means. All right, so you can go ahead and go to the next slide. This for us was new, but finding out that active military service, it only lasts my husband is a rarity, someone who, spent 22 years just, and retired. Usually someone does, they're 4 years, maybe 8, and then they're done. But those impacts are really lifelong, and especially when it comes to the mental health challenges with the post-traumatic stress disorder, traumatic brain injury, depression, anxiety, and substance use disorder. And when you think of all of these things, we usually don't correlate those with any kind of dental interactions. But one of the things that I'm going to share a little bit later is the trauma-informed care and how this was like one of those aha moments for our team. So I just want to make sure that you all think about that. And even if someone served for 4 years, there's a very good chance that they are going to suffer from one of these mental health challenges. And that's something we really need to keep in mind as oral health professionals. All right, go ahead, next slide. Substance use disorder is high among those that have served. We include smokeless tobacco and smoking and in those, but excessive drinking. And I'd like to include this just because it's like one of the statistics that we love to share is that approximately 1 in 10 veterans who have visited one of those veteran hospitals have met the criteria for substance use disorder diagnosis. And that's pretty significant. And I know that's probably higher in some states like West Virginia, who already has a very high substance use disorder population. So I just want to throw that out there too, just so you know that what we're kind of dealing with. All right, next slide. And across the board, 56% of veterans have visited the dentist. So that's not bad. 42% have reported having period disease. Now, these are all self-reported, and these statistics are from our friends from AIDPH and CareQuest, and we put that little QR code. So if you want more details, that'll take you directly to those resources as well. So if you want to share these later. And 8% of veterans have lost all their natural teeth. 56% have active decay. Again, and like I said, these are self-reported numbers. That's why we're kind of excited to see what our oral health surveillance, when we look at the veterans, is really going to look like when we look in their mouths to see if that's really higher, if it's lower, and where those numbers kind of match up. 45% have reported having permanent teeth removed due to pain and infection after the separation from the military, and 41% describe their oral health as fair or poor. And that's going to be kind of exciting too, to see what those results are. But I'll go ahead and let you go to the next slide. And again, just a little bit in West Virginia and how we compare to those national averages. Ours aren't so good. We're a little higher, as you can see, for all of those things. And West Virginia rural veterans are a little higher as well. So we have our own barriers, but I don't think they're really much different than what everybody else in the nation is facing. All right. Go ahead to the next slide. All right. So veterans really can't be healthy without oral health being included into that. And one of the things that we wanted to look at was really what were those true barriers to care. And Liz did the poll. And are you going to share those statistics or those what everyone was saying a little bit later?
We did. Let me see if I can go back. Or Sam, are you able to look and see if we can repost them? So the highest amount, 46% of folks said lack of dental insurance. They thought was the most significant barrier. 20% said shortage of providers familiar with veteran-specific needs. 15% said transportation and geographic isolation, and 20% said limited awareness of available resources.
That's not surprising, but it's, when you think of 85% of our veterans enrolled in the Veterans Health System aren't eligible for dental services, that's really not surprising that that's our number one barrier, is that cost of treatment and that eligibility confusion. For those of you that aren't aware, you have to have 100% disabled criteria, or I'm trying to think what they call that, Liz. You can probably help me, but they have to have that designation to be able to have complete dental care covered. There's some loops that they can jump through if they're not 100%, if they can tie it into a medical service connected. Thank you, Patrick. Yeah, service connected. It has to be 100% service connected disability. There's some, but you have to have, if you're gonna, I hate to say work the system, but if you have less than 100%, if you have a medical provider who can say, well, you need to have, one example that I know that we have run into is someone with COPD and needs a sleep apnea, or the sleep apnea machine doesn't work, and they're looking at the ones that go in their mouth. So they connected that so that they could get their teeth fixed, so that they could wear the appliance. But you have to have a provider that's willing to do that and know those loops to jump through. The geographic barriers, I just highlighted the West Virginia ones, and I don't think those are really much different from anyone else. And especially when you consider, like, a lot of the veterans that are older, maybe don't have transportation. They have to have gas money. They maybe have to have someone drive them. There's a ton of barriers with the geographic and transportation that are there. And that cost of treatment is definitely one of those things for those that aren't 100%. And we're going to talk about a little bit of that, of the cost of treatment and some of that confusion around eligibility. And even if you are going to buy the supplemental, there's some really things that are bothersome when you look at navigating that system as well. All right, so one of the things that we stuck on there was past experiences. And this is where that trauma-informed care is going to come in. And I'm going to talk a little bit about that. And that was something that was new to our team whenever we started down this path. All right, so you can go ahead and go to the next slide. All right, so when we started out about the cost of care and the confusion about eligibility, and we were looking at all of the different options. And we knew that if you were 100% service connected disability, you could go to the VA and get those services. You could also get what was called care in the community. And as I mentioned before, that was one of those things where you have to go and work the system. You have to be so far away from the center itself. The wait time has to be significant, and it has to be a burden to go there. And then one of the things that we are finding out is, if you're able to get that care in the community from a local dentist and they do a treatment plan, if that treatment plan changes, you have to start over again. So if you have a patient that you have pre-authorized for a prophy exam, x-rays, and you're going to get them in, and you get them in, usually we do those all in the first visit. If you find out they need root planing and scaling, you have to resubmit all of that paperwork and get that approved, and then you're going to get it back. And we all know that you need to take care of things when you've got the person there for many reasons. And especially with our veteran population, when you think of all those things that we've already talked about a little bit, whether it's, transportation getting there, some of that anxiety and things that we're going to talk about when we talk about trauma-informed care. So it's really important that, we have them in the chair. We need to take care of as many things as possible, yet we're not going to get paid for it. And we all know that, especially in the private sector, well, and even the community health centers, we still have to pay the bills. So we really can't expect people to be, performing these services at no cost, because we still have to keep the lights on. So this little QR code will take you directly to what the veterans call their care navigation piece. And I'm just going to say this, and I hope I do not offend anyone. If you can, and that's why I told Liz, I'm going to pause here, because if somebody has a better technique of doing this, we want to hear about it. Jana from our team actually got on the site. She's our data guru, and used her parents, her dad, and he actually went ahead and she was putting all of his information in. You have to put your zip code in, and then you have to put your exact service. So if you don't know exactly what service you're putting in, it's going to tell you that there's none available in your area. And depending on what your zip code is and where you put it in, if you don't know where those hospital systems are or those VA centers are, you may not get what you need to find as well. So it's really not easy. And when you think of all of our veterans who are not technology savvy, like we have the know-how, we have the technology, we have computers, we have iPads, we have and we made it our mission to try to see how difficult the system was, and we still struggled to get an appointment made. We picked up the phone, we made phone calls to all 4 of our veteran centers, and it took on average about 30 minutes to get to where we needed to get to find out someone to talk to, even to say, can I schedule an appointment and am I eligible for benefits at your center? And then those that answer the phone don't always know what they're talking about. And then they pass you on to someone else. And when you think about the veterans, it's really, really hard to expect them to navigate that system. And I'm looking at the comments there. Shonda said technology issues, it's wide, and it's just not oral health. And I think we're going to see, as the system keeps pushing toward the technology and the paperless, we're going to see that isolating a ton of our veterans and a ton of our older population folks. So with that being said, I'm going to pause here. And I know some of you have already put in the chat, if there is something that you have found that's an easier way to help our veterans navigate this system, or a website that we haven't paid attention to. I think Liz, did you share that in the chat? I think I saw that come up.
Yes, I copied what was on your slide here. So
Okay, great. Yeah, it's there. So if anybody, has anything other than what we have already found, we would be glad to hear it. So if anybody has that, I'm going to pause for a few seconds.
I don't want to cut anyone off, so please still feel free to jump in. Bobby, I'm also wondering, do you find that rurality also plays in with this tech piece of there's added barriers? They might not have the connectivity or the technology to even get there, never mind the fact that it's very hard to navigate once they do.
Oh, very much so. And we're seeing that as a, and Jana uses her dad all the time, is he's just like, oh, heck with it. Only he doesn't use the word heck with it. It's not worth it. It's not worth it. And that if they're frustrated with that, and they also know the importance of it, just think of those that aren't seeing oral health as a priority. Sean, I see Sean raised.
Well, I just want to say, and want to recognize CareQuest. We received a grant for a hospital-based dental program, and we have an expanded practice hygienist embedded in the hospital. And she started seeing a lot of veterans, and the time that she spends connecting vets to care, and oftentimes, just as you've said, Bobby, they don't qualify for anything from the VA. So she's trying to hook them up with our local community health clinic. But it takes so much time, and my heart goes out to these veterans, because without somebody like our hygienist who gets it and is willing to take the time to follow through with their treatment plans, I mean, these folks would get nothing. So I just thank you for raising the issue, and I think the more we talk about it, I think the more awareness to the issue. That's it.
Oh, thank you for sharing that. And I'll just add too, is one of the things that we have, discovered is for those that aren't 100% disabled, there is also an option to purchase a couple different programs administered through the veterans organizations, but it's kind of like that bad insurance of, you can pay $85. It's coming out of your already limited income, and you're still going to have to pay a copay, and it maxes out at whatever, and you have to find a dental provider that's going to take it. And in West Virginia, hardly anyone is willing to take what we have here is called TRICARE. And when we called around to the dental offices, pretty much the only folks that we could get to take that or that would accept that is our FQHCs, because it's just the paperwork, the reimbursement isn't great. So that's a really, yeah, someone just commented, TRICARE coverage is terrible. And it is. And that's another option. So there really isn't a good option. So now we can see why cost of care, the confusion part, is really one of the probably the biggest barrier that we have identified, because I think that they just give up. Why would you try to navigate this system, and yet it's so important. So I will quit talking again for a few minutes. Does anyone else have anything? I don't know if there's anything in the chat, Liz.
Yeah, I think Jan's posting in the chat about things changing with VA services being interrupted, and talking about in-home dental services not being covered. So looking at potential changes coming down the pike. I'm not sure we can predict those, but I don't know if you have thoughts there.
Yeah, I think not just with oral health, but I think everything is changing with our veterans, and those benefits, and how it's a wait and see situation. And I think everybody just kind of is holding their breath to see what these policy implications really have on direct services, mental health, especially, and oral health are two of the biggest. But I think, I wish I had some answers there, which I don't.
I know, and it's hard. I'm not sure even anyone knows where we're going at this point or where things will end, and maybe just to a call to us as a field for us to keep our eyes and ears open about ways to collect that data if necessary, or keep tabs on those pieces and look at those surveillance systems that need to be implemented, because that will be a part of it, of trying to kind of push for additional change if depending on how things go.
Yes. All right. But before we jump into trauma-informed care, does anyone have anything else about coverage or anything like that? If not, we'll go ahead and go to the next slide. And the next barrier that our team found was that the one that was the previous experience. And our team went through this intensive training with one of the behavioral health specialists who focuses on veterans' mental health. And we learned so much. And I'm going to pause right here and just say, if there's anything that you take away from this conversation today, it's please learn more about trauma-informed care. It's not anything that was on the radar when I was in dental hygiene school. I'm not going to tell you how many years ago. It wasn't anything that we had taught our residents at Marshall until we all experienced this. And we're like, oh my gosh, there's so many things that are impacting the care. So I just want to make sure that I make that plug. Please, please, please learn more about trauma-informed care. And it really changes the narrative from a what's wrong with you to a what happened to you scenario. And when we think about our veteran population, this can be anything that they experienced in deployment. It could be something that happened during boot camp. It might be something they witnessed. It may be something that they actually had to do themselves, something they saw, something they smelled whenever there's so many triggers for them. And Brittany from our team always says, we need to approach trauma-informed care like we do universal precautions for infection control and OSHA. We need to make sure we have when you walk in a dental practice or an office, that system is there, that that they're going to have gloves on, that they're going to have a mask on, universal precautions is there. We need to really start implementing that within all of our healthcare practices and making sure that we have that universal precautions and creating that system that we approach every patient, not just our veteran patients, but with that trauma-informed care heart. So that's kind of why we do this. But when you think of that trauma that the veterans have experienced in the dental practice, holy moly, we are like trauma trigger 101. We have compressors that are going off, on and off loud, depending on what room they're in. When you walk in a dental office, the smells, there's all kinds of smells. Any of that can be a trigger. We walk in the waiting room, maybe on, if your receptionist wasn't even thinking about what was on, and all of a sudden there's news coverage about some conflict overseas or some, horrible show that might be on. Like we don't think about, there's so many things we don't think about, but the dental office is a trigger within itself. And then especially when you like peel back and look at all these other little things that are going on in your office. You know, someone who has been triggered, and my husband is one of those, who crowds or some set like make him extremely anxious. And the same thing with the unknown. So for him, if we walk into an office, and it doesn't matter whether it's a dental office or what kind of office it is, if his appointment was at 2 o'clock and it's 2:15 and he hasn't been taken back, he starts to get agitated. He wants to make sure he has a plan. He wants to know what's happening next. And for dental practices, a lot of times we can't do that. We get behind, but making sure that we communicate that. So I'm just going to share a few things about the dental experience that we found, because I could spend an entire day, probably entire week, talking about trauma-informed care and how we can improve that approach with our patients, but I don't have all day. So I'm just going to share a little bit of things. But the first thing I want to share is we as dental providers just come in and we're like, hey, how are you doing? We grab the napkin and the napkin chain, and what do? We just wrap it around the patient and we go ahead and hit them on the shoulder and say, I'm going to lean you back and we're going to get started. And until we had done this training, our team had never crossed our mind that could be a trigger for someone. Anyone that had been in a situation where they might have been strangled or had something around their neck, we're wrapping a napkin chain around their neck without even asking. And what do? We hit them on the shoulder, or we pat them on the back and say, hey, how you doing today? And we really should ask permission. How are you doing today? Is it okay if we go ahead and get started? Asking that permission and getting that from the patient goes a really long way. So those are some of the things I'm going to share with you today. You can go and go to the next slide. And one of the things that our trainer shared with us was a study that she had done, and it was looking at the trauma experience with dentists. And these are 9 of the things that they said, I wish my dentist had known, or I wish I could have told them. And I'm just going to read through these real quick so that you guys can kind of be thinking about your patients and those that you serve and thinking, oh my gosh, like that is a person. The first one is, I feel disgusting and I'm convinced that you perceive me that way too. Number 2 is, I must always evaluate what could be the wrong answer. And when you think of our military personnel, there was always a wrong answer and a right answer. And if they gave the wrong answer, they were punished. Like that's not acceptable in that hierarchy. So those are some of the sort of things when you ask someone, are they going to be in trouble? Number 3 is, my body was prepared to expect violence and humiliation every second. So no matter how much I trust you, I don't know that I can. And you think of that too, when you think of like even just the tear down of the boot camp mentality and how they build them back up. Some of those things, I mean, it's just so impactful when you think of how a dentist and a dental appointment is going to impact them. I will endure anything unpleasant and I will not stop you. And I see this a lot within our own house, that threshold of pain, you can't show weakness. I don't know if that's just a Marine Corps thing or if that's across all the military sectors, but I know it is at our house. I would like to tell you, and at the same time, I'm afraid to. And there again, it's that sharing. Like if I do share with you, I'm this big, tough guy, but if I share with you that I'm afraid of the needle, or that I don't want that wrapped around my neck, or that smell of burning tooth is going to be triggering to me, am I showing weakness? The 6th one is, I believe everything is my fault. Number 7 was, allowing you to touch my mouth is the most intimate thing I can imagine, and it is really hard. Number 8 was, I always expect you to get angry at me or reject me. And number 9, which I think is just really eye-opening, is, I sometimes believe I'm making this all up or I'm acting to get attention. And I think a lot of times if someone has suffered that trauma, in their mind, they're trying to make that realization, is this really real? Is this something that I'm really experiencing, or am I overreacting? And it is real. And we need to make sure that we realize that someone who has had trauma, they don't have control over that anxiety, that sweating, that, nervousness, the gripping of the chair, the things that we see. So we need to give them a lot of grace. And those are the ones that they wish they had shared. So on the next slide, if they don't share that they have the trauma and they don't, how are we going to know? And how may this manifest with a patient? And the fact that they are very unlikely to share what might trigger them here's what we might see is that frequently missed appointments, reluctant to discuss health problems in general. Oh yeah, I'm fine. I'm okay. Nothing's changed. Some confusion, poor memory, challenges to adhering to treatment or recommendations, varying perceptions of experience and pain. We really should never tell a patient, oh, that didn't hurt, because it's not up to us to determine their threshold of pain and whether something is really hurting or whether that's something that they really need, they shouldn't be saying to us. If they avoid services, postponing appointments, cycling in and out of crisis, and delaying care until they absolutely have to. And we probably see this among our veterans a lot. They'll have a little bit of a toothache, they put it off. They put it off until, the filling now becomes a root canal, and the root canal then that they put off then has to become an extraction. And it really truly takes time and intention to develop the skills as professionals, that to know that we can help our patients. And that's why it's a continuous evolving thing, that we see our team even doing. And so I'm going to pause here because I see lots of things coming up in the chat. So Liz, you want to let some folks comment there?
Yeah. And Carol, I don't know, Carol, since I know you, I'm going to put you on the spot. Do you want to share what you were saying off mute? I can always read it for you if you're not able.
Sure. Can you hear me?
Yeah. Mm-hmm.
Trauma-informed care, I too, Bobby, share the passion for that. I absolutely think that's something that all dental professionals should have education on. And then just what you were talking about, the things I wish my dentist knew, and if they don't share, how will we know? Would love to have some of that in writing so that, we could share that with, colleagues and such. Absolutely love everything you had to say, but particularly here on the trauma-informed care, it's so important for veterans. So, and many others, as the next comment says, it is definitely something we should apply to everyone, like standard of care. That's perfect. So thank you very much.
Oh, you're welcome. And I will include my email at the end of the slides too, because I have some other things that folks might want. So by all means, and I think Liz will share whatever resources and things we have too. If anyone has anything else, Liz, or if you're ready to go, because I'm going to next share a little bit about what we, some of the easy things that we found were you were able to implement in your practice. Coming from a university setting, anybody that's part of a bigger organization knows that you have to, it's basically a letter from the Pope, a letter from the president, and then 4 more signatures before you can make any changes in anything that you do. And some of the things that we found that were easily implemented without being big policy changes, that were having the cold compresses. Cold calms the sympathetic nervous system. So having those ice packs for someone, that if they are agitated or you can see them get hot and flushed and nervous, having that ice, they can just put it on the back of their neck, get them cooled down. The rubbing stones have been a huge hit. And that was one of the things that our trainer suggested. And she said that one of the things that they use in the VA that she works with is they have, of course, they have I think it's called auxiliary. I can't remember the name of it, but it's a group of women. They make the lap gowns for some of the wheelchair patients, but they sewed little squares with different kind of fabric, then like could crinkle and things like that. So just when you think of like fidget things that kids would like, it kind of occupies their mind and their fingers. So those are sort of some of the things that we have given out during our trainings. But the one that has been probably the most just like people are raving about is our anxiety thermometers. And when Carol was talking about wanting the list, this is something if you all want, I can email it out as well. And what we have done is we have laminated it so that you can either keep it chair side, and then after the appointment, you can either wipe it off if you need to, or you can hang it in your operatory. And we have received amazing feedback about those as well. So if you want to go ahead, someone said using scent infused stress balls. That's a great idea too. I hadn't even thought about that. So that's good. If you want to go to the next slide, those are some of the tools that we talked about. Yes, Paula, I will make sure we email all of these. Is some changes that you could make to your intake forms. At Marshall, we don't ask, are you a veteran? have you suffered from trauma or, trauma experience? So what we have tried to do and indoctrinate into our residents is, even though it's not on the health history and it's not on the intake forms, have that conversation during that initial appointment. And so whoever's doing that, if it's a resident, if it's the assistant, if it's a dental hygienist, whoever, ask those questions, because we always say, oh, how are you doing? How's the family? We say those sort of things. So why not say, hey, so, and our military veterans are so proud. They usually have their hats or their shirts. My husband wears his Marine Corps stuff everywhere. So it's easy to say, oh, you were a veteran. And, some of the things that we're talking about with our veterans is trauma-informed care. Is there any experiences that maybe I should be aware of before we start your treatment? Having those conversations, even if you can't change the health history forms or those intake forms. And some of the other things, and I'm going to talk about tobacco here in a little bit, is the asking them if they use tobacco or they vape. And one of the things that one of our colleagues, who is a veteran herself and a dentist, said that she was so surprised, because when you say, do you use tobacco products, or do you, they'll say no, but they vape. So they don't correlate those as being the same thing. So I'm going to talk a little bit about that here in a little bit. But just having the forms too filled out, having as much done ahead of time, if you know that patient's coming in and they are a veteran and they have some of that trauma experience, it's going to impact their appointment, so that they don't have to wait in the waiting room. If it's the 70-year-old man who is cantankerous, sweet as can be, but he loves being a curmudgeon, and he's going to have to be in the waiting room with, a family of 6 who can only come at that time. And their kids are feral and they're running all over the place. So he's going to be agitated. So let him sit in his car, text him and have him come in, or call him, or just even let him sit in the car and go out and get him when it's time, so that he's not agitated already by the time he comes in and is lecturing them about how, as my dad says, feral or gentle parenting's for gentle kids, and your kids are feral. So instead of doing that, like thinking about making that an individualized appointment from the very beginning all the way through the end. Making sure, as I mentioned, what's on TV, and making sure that we don't have some, anxiety level. And nowadays it's hard, almost every channel, don't put it on the news. That's controversial already all around. Don't do that. So making sure all of that stuff that you think about for when you go to do trauma-informed care. And I will be sure and share all of this. So I'm going to go ahead and move to tobacco, because I don't know how much more time I have, Liz.
Well,
And
I was just going to give you a double tap. I think we have about 2 minutes left. So I'm
I
sorry
like to talk.
give
Have
you
you
a
figured that out?
warning earlier. But I
I'm
know,
sorry.
no apologies. A few things. I will hand it back to you in a second to kind of give a closing remark, and then I can give folks next steps. We've talked about several resources that we want to share from you. We can share those in the Academy, and we'll share your slides. So maybe just a note about, there's some additional fantastic information in your slides and your contact information. If you have any other notes for folks, if they have questions or comments about the stuff in slides that we might not have time to fully cover today.
Okay, yeah. If you want to go ahead and advance all the way, then my tobacco ones are there. But if you just want to keep going till, let's see here. Yeah, we included tobacco and they're ready to meet. Okay, let's see here. This is all still tobacco. Okay, yeah. There you go. There's my email, my phone number. By all means, call me, email me. Like Liz said, we'll put everything in the Academy, and I will be glad to, try to help as much as I can. And if anybody wants to know how we got started, or wants us to share resources or our forums or anything, we'll be more than glad to do that. And I will stop talking. And if there's any last remaining questions, and I am sorry, I do like to talk, and I knew this was going to happen.
No, like I said, absolutely no apologies. This was an incredibly rich presentation. We're so fortunate to have you. And I didn't give you a warning any earlier. So
No,
is
you're
fine.
good. You are good.
I'm going to talk about our next steps. I will say if folks want to keep chatting in the chat, someone did mention that when we're talking about tobacco, we also have to ask if there's cannabis use for those products. And someone else is wondering if folks are going to admit that if it's a state where it's not legal. So if folks want to answer that or comment clinically in the chat, that would be fantastic. Shayla, if you don't mind advancing to our next slides, I can let folks kind of know how to get all of these wonderful resources that we can pass this one. So back one more, sorry. As we said, CEUs are available. Sam and Shayla are posting. Sam just posted in the chat for the CEU link. That brings you to the Academy. That space will be where we post the recording, where we post these slides, as well as some of those resources that Bobby so kindly mentioned and generously offered to share with us. That might take a day or two. We will also email out this registration list when that information is there in the Academy, so you can be sure to access it. That is free and open to access, and so if you have colleagues or peers that you think would find this information useful, we encourage you to share it there, and also look forward to our future sessions. You can go to the next slide real quick, and just a plug. This was a lot of conversation around veteran oral health, specific to rural veterans, but veterans in general as well. And I want to share that there is an open Hill Day in May, and we encourage you to sign up. Veteran oral health is going to be one of the issue topics there. So if you feel activated on this, please check out that information. Registration is still open. Having you in person in DC would be wonderful, of course. But there are also opportunities for participating virtually if you are unable to travel to DC for that. So strongly encourage you to take a look at that. If you're watching this information asynchronously, we will also have a post about open in general if you're interested in getting involved in advocacy work around veteran oral health and oral health access for other populations as well. And we can head to the next slide. I think that brings us to the end of our content. Thank you everyone for your grace. We're a few minutes over. Please join me with a very warm and big virtual round of applause for Bobby Steele. Thank you so much, Bobby, for being with us. Thank you, community, for being here with us and engaging in such a dynamic conversation in the chat and in discussion as well. Have a great day, everyone.
Thank you. Like I said, I don't mind sticking around.